case of 25 years old woman who presents to the emergency department for fever. The fever is going on for last 2 months and she has some shortness of breath and malaise. What are the possibilities? What is the most likely cause of this fever? There's a 2 months fever. Doesn't have much complaints except that she has some shortness of breath and malaise. And what are the possibilities? Yes? Considering the possibility of tuberculosis with high prevalence in our country, tuberculosis can be one reason. It's chronic fever with shortness of breath, so pulmonary tuberculosis. She doesn't have any cough. Then what sort of tuberculosis would it be if the patient doesn't have any cough? Which tuberculosis will be without cough? If it is pleural, or if the patient has miliary type of tuberculosis, may not be cough there. Lupus, female, fever, malaise, IE, and empyema going on. So these are the possibilities that this patient might be having. Now we see further. Physicals, she is mildly anemic and got splenomegaly. Now what do you think has happened? What is the possibility now? Is it typhoid? Typhoid is not that chronic fever, low grade, huh? Still, tuberculosis remains on top because the patients have splenomegaly in miliary type of tuberculosis. Infective endocarditis, SLE, way down the list. Labs show a hemoglobin of 10 and ESR of 65 millimeters. Ultrasound, splenic enlargement, chest X-ray, slightly dilated heart. Now the key investigation is echo. It shows dilated LA and LV with moderate MR and a soft mass attached to the posterior leaflet of the mitral valve. So this is infective endocarditis. This is how it presents. This is how we proceed. Now what is infective endocarditis? What is this? Anybody? I think you should know it. G? What? So it's the inflammation of the endocardium. Acute or subacute inflammation of the endocardium. Sometimes it can be non-bacterial as well. It may be viral, it may be fungal. In fact, it may be non-infective as well. So do you have non-infective endocarditis? What is that Libman sac? It's infective? It's not infective. So you can have non-infective. So we are going for infective endocarditis. Our topic was IE. Now how you make diagnosis is using the Duke's criteria. What are the Duke's criteria? Yes? There are 2 major criteria if they are present, 1 major, 3 minor criteria, or if there are 5 minor criteria. What are these criteria that determine the presence of endocarditis? It is what are the major criteria and what are the minor criteria. Now what are the major criteria? 2 blood cultures, 2 positive blood cultures and echocardiographic evidence of possibility of endocarditis. Now what is this echocardiographic evidence? Yes? Presence of vegetation and abscess and dehiscence of valve. So these are echocardiographic criteria which suggest that this is endocarditis. Now what are the minor criteria? Predisposing factors, for example, patient has congenital heart disease or mitral regurgitation or AS, etc. There is chronic fever, embolic signs. We will see what are these embolic signs. One, positive blood culture, complex immunological phenomena like glomerulonephritis, arthritis, positive RA factor, ocular node, rod spots, serological confirmation of infection, and echocardiographic signs not meeting the major criteria. So, for example, if you find only there is aortic stenosis on echo, which does not fulfill the criteria for the presence of endocarditis, that is vegetation or abscess formation. So if there is an echocardiographic evidence which does not meet the major criteria, so all these are minor criteria. So if with a major 3 are present or 5 of them are present alone, this is infective endocarditis. So you remember that the diagnosis of infective endocarditis is made on this Duke's classification. 2 major criteria, 1 major or 3 minor, and or 5 minor criteria. Major criteria are 2 positive blood cultures and echocardiographic evidence that this is endocarditis. Now, what are the risk factors for the development of endocarditis? Who are the patients who develop endocarditis? So, residual valve injury, if the patient had rheumatic fever or there is pacemaker intervention or any intervention which can damage the valves. Patients have congenital heart disease. We'll see what congenital heart disease is. IV drug users, patients who are immunocompromised, advancing age, and prosthetic valve. This is the most important. Now we have the infective endocarditis prevention guidelines. When do we use prophylactic antibiotics? The most important of these is prosthetic material present in the heart. So what were the previous guidelines? If the patient has this lesion, if the patient had previous endocarditis, you should go for prophylaxis. Now these guidelines have changed. We'll see what are those guidelines. Now it's a common disease. Typically affects older people. Children may present without evidence of valve disease. You may not find valvular disease. They may still have endocarditis. Mitral valve is the most common. Then you've got aortic valve, then tricuspid valve, and pulmonic valve in cases of native valves. If they are valve replaced, this thing changes. So this is in the native valves. If there are natural valves. If there are artificial valves, this equation changes. Tricuspid valve disease is associated with IV drug users. So usually we do not see tricuspid valve involvement in endocarditis. Why? Because it's a low pressure valve. The pressure across tricuspid valve is not that high. So endocarditis of this valve is uncommon. It's seen with IV drug users. Now, what are the organisms which are generally involved? In bacterial endocarditis, if there is acute endocarditis, Streptococcus pneumoniae and Streptococcus pyogenes, you've got Staphylococcus aureus. It's more of seen in drug users, and if there are larger vegetations, their vegetations 1 centimeter or even bigger than 1 centimeter, presence of Staphylococcus is a high probability. And then you've got Neisseria. You've got chronic endocarditis, or what we call subacute endocarditis, is Streptococcus galacticus. And now this organism is associated with colon cancer. So any culture, if it grows and shows that there is this organism, one should go for colonoscopy. So this is associated with colon cancer. And if you are doing a colonoscopy and you find this organism present in the stool culture, look for the heart for the presence of endocarditis. Enterococcus in GI and genitourinary procedures have been done. Streptococcus viridans, if there are dental procedures or upper respiratory tract infection, is staph epidermidis, prosthetic valves. So these are different type of organisms usually which can be isolated from patients who've got infective endocarditis. So in acute cases, it is the Streptococcus and Staphylococcus. In chronic, it is these two organisms. Candida in patients who are IV drug users. So this also produces subacute type of endocarditis. Then you got other fungal infections which can cause subacute endocarditis. So the patient, they present with persistent fevers. They may be low-grade fever. In acute cases, they may even be high spiking fevers. And if a patient has chronic fever going on and then starts developing spiking fever, what has happened? Suppose we have got a patient of chronic endocarditis and the patient was having low-grade fever going on. Now the patient starts having spikes. What has happened? Abscess bun gaya. So when do you have spiking fevers? It's malaria, it's UTI, it's cholangitis, and it is localized abscess. So you are spiking fevers. So if the patient starts developing these spiking fevers, this may be acute endocarditis or this may be abscess formation. Patient may have shortness of breath with associated heart failure. Systemic symptoms include there may be weakness, fatigue, malaise, myalgias, arthralgias. There may be headache. The patient may have nausea and vomiting. So these symptoms are not really very specific. They are very vague symptoms. That can happen in many diseases. For example, all these can happen in diseases of the liver itself. Chronic hepatitis can present with these sort of features. So these are very vague symptoms. That's only one thing we suggest that heart may be involved. Physicals, precordium may show murmurs. There may be murmur of MR, there may be murmur of AS or AR. The more important is a new onset murmur or changing murmurs. If the character of the murmur during the course of the disease is changed, then it's very high likelihood that this is endocarditis. But this can only happen if you already know the patient or you're following the patient. You go for daily assessments. So this symptom was actually in the past. You admit the patient, you don't know what's going on, you daily listen to the patient, you find that the murmur has changed. So this is endocarditis. Or if the murmur is started anew, so this is endocarditis. But now you see, when you get this patient of fever, which has, which includes in its differential diagnosis, infective endocarditis, we can go for an echo straight away. And we don't have to wait for those murmurs to change. So I think this should be changed from the books now. क्योंकि कौन इतनी देर इंतजार करता रहे कि ये मर्मर चेंज हो तो मुझे पता लगेगा कि इसको एंडोकार्डाइटिस है, इतनी देर में उसका वैल्व भी उड़ जाए. चेंजिंग मर्मर का मतलब ये है ना, regurgitation has started. So that means it has taken eternity in diagnosing the disease. So books still say that, new onset and changing murmur. Obviously this is a very strong point in favor of endocarditis, but personally I would not like to wait. If the patient is having fever for so many days and the cause is not known, I would go for an echo and see if there is any evidence that the heart is involved. I will not wait for the murmurs to change or new murmurs to appear. That would be disastrous for the patient. So you have to go preemptively. You don't wait. Peripheral signs, patient may have anemia, there may be splenomegaly. Patient may have embolic phenomena like Roth spots in the eye. These are retinal hemorrhages seen on fundoscopy. Janeway lesions are macular lesions. They are non-tenders. They may be seen on the palms and soles. Then you've got nail bed splinter hemorrhages and immune complex deposition like osseous nodes, which are seen in tender nodules in the palm and the sole. So you just see, you find tender and painful nodules in the distal phalanges, or they may be found in the soles. But I have not seen personally these. I have seen many cases of endocarditis. I have not personally seen, except for these splinter hemorrhages or occasional these Roth spots. I don't have seen these osseous nodes and the Janeways. The cardiologist may have seen more of it. So evaluation is blood culture. So any patient who comes to you in the emergency or OPD with fever, especially if it's a chronic fever, immediately send the blood cultures without giving any antibiotics. The problem is that when these patients come to you, they have already been given some antibiotics by the general practitioners. So that changes the blood culture yield. Echocardiographic evidence of vegetation embolizing, multiple vegetations which are bigger, mobile vegetations, non-calcified vegetations. The possibility is that these vegetations can embolize. Culture negative endocarditis occurs in 5 to 12% of cases. Now, what are these culture negative endocarditis? These may be viral endocarditis, these may be fungal endocarditis, but the antibiotics can also change. So, prior antibiotics or fastidious organisms, the organisms, fastidious organisms which have special requirements for growth may not grown on ordinary cultures. So these patients may have culture negative endocarditis. ECG may reveal conduction delay if there is aortic root involvement. CBC and ESR may show anemia, there may be leukocytosis, ESR may be high. Ultrasound may show splenomegaly and organ abscess. For example, it is embolized into the liver, it may produce a liver abscess or a splenic abscess. Urine analysis, there may be hematuria or proteinuria. Now, what is the treatment of infective endocarditis? This is one disease along with meningitis where treatment should not be delayed. You send the blood cultures and start the empirical treatment. If you're considering infective endocarditis, it is criminal if you delay the antibiotics. In meningitis and in infective endocarditis, should not delay by, I think, more than 30 minutes. Immediately take the blood cultures, start the antibiotics. What are the empirical antibiotics used for endocarditis? It's vancomycin and gentamicin for a period of 4 to 6 weeks. Antibiotics can be adjusted depending upon the response. If the patient starts showing good response, you continue with the antibiotic, whatever is the report of the culture. But if the patient is not responding or the culture reports is contra to it, you can change the antibiotics. Treat the heart failure, surgical intervention. When is surgical intervention required? Fungal endocarditis except for histoplasma capsulatum. Congestive heart failure which is not responding to medical treatment. Persistent sepsis despite antibiotic therapy. Fever is not settling. Leukocytosis is not settling. Patient symptoms are not settling. Think of surgery because there may be abscess formation. And vegetation may be removed. Conduction disturbances caused by aortic root involvement. Recurrent septic emboli, consider surgery. Kissing infection between aortic and mitral valve for intractable heart failure. If the valves, they stick to each other. This is an indication for surgery. So all these are indications for surgery. Amphotericin B and 5-fluorocytosine for fungal endocarditis. Now, what are the differential diagnoses of endocarditis? Atrial myxoma presents with murmur and chronic fever. You can easily diagnose on echo that this is left atrial myxoma. Right atrial myxomas are present, they are uncommon. More of them are on the left side. These connective tissue disorders, intra-abdominal infections. Which intra-abdominal infections can present like that? One is hepatitis, the other one is chronic liver abscess, especially the embebic liver abscess. That can present with chronic low-grade fever and similar symptoms. Lyme disease. What is Lyme's disease? Borrelia. So it is borreliosis. It presents with multi-system involvement. Primary cardiac neoplasms, polymyalgia rheumatica. So now, when do you want to give infective endocarditis prophylaxis? Prosthetic valves. So you remember, whenever you've got this material inside the heart, you have to give endocarditis prophylaxis. Now, what is the advantage of giving endocarditis prophylaxis? There is a lot of debate on this subject. Is really prophylaxis required? Can, with the prophylaxis, all patients' infection can be prevented? नहीं? पक्की बात है? हाँ? We're talking of bacterial. Because when we do these, why are these prophylaxis given? Why is this prophylaxis given? When the patient has underlying lesion which can cause infective endocarditis, and if you are doing a procedure that can result in bacteremia, for example, if you're doing dental manipulation or doing catheterization, respiratory procedure or GI procedure, that can cause bacteremia, so it will be bacterial endocarditis. So there you want to give antibiotics. But you see, giving prophylactic antibiotic does not mean that in 100% of cases you can prevent endocarditis. That's why the guidelines have changed. Dental surgeons, orthopedic surgeons, they all agree that the guidelines need to be changed, and they have been revised. So if there is a prosthetic material involved, prosthetic cardiac valve, including transcatheter aortic valve replacement, prosthetic material used for valve repair, e.g., for example, this annuloplasty rings and cords, cardiac transplant with valve regurgitation due to structurally abnormal valve, congenital heart diseases with any type of cyanotic congenital heart disease, any congenital heart disease repaired with prosthetic material. So prosthetic material का मौजूद होना चाहिए. This is a very strong indicator that these patients should be given endocarditis prophylaxis. Repaired congenital heart disease with residual defects at the site or adjacent to the site of a prosthetic patch or prosthetic device. Cardiac transplant recipients with cardiac valvular disease. So these are the patients in whom you should give endocarditis prophylaxis. Now, what drugs are used for endocarditis prophylaxis? Amoxicillin. So if the patient cannot take oral medicine, you can give ampicillin, IV or IM, cefazolin or ceftriaxone, IM or IV. Patients who are allergic to penicillin, they can be given this cefalexin or first or second generation oral cephalosporins. But you see, any patient who shows immediate type of hypersensitivity reaction to penicillin, cephalosporins should also be avoided. The patient shows acute allergic reaction like urticaria, anaphylaxis, angioedema, these patients should not be given cephalosporins as well. There's a possibility that they can have allergic reaction to this drug as well. There you can use azithromycin or clarithromycin or doxycycline. So you use these drugs. First drug is amoxicillin. If the patient is allergic, you can choose between azithromycin, clarithromycin or doxycycline. Now the complications, you can remember these complications? Now what is this? Sinus of Valsalva aneurysm. What is sinus of Valsalva? What is this sinus of Valsalva? Sinuses of Valsalva are pouching in the semilunar valve where the coronary arteries, they emerge. An aneurysm of this can lead to compromise in the filling of the coronary arteries. So you can have these complications from infective endocarditis. And now again, arterial emboli, these are the example of emboli. Emboli है ना, ये जो stroke होता है. Embolism की वजह से तो vegetation टूटती है और जाकर कहीं फंस जाती है. So it can produce embolism in the brain, in the gut, in the limbs, in the kidney. So it can go into multiple places. Myocardial abscess and conduction defects. So these are different complications of infective endocarditis.